This episode of Pupil Pod is supported by Dompe.
Welcome to the Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Sila Bal, and my guest today is Dr. Dee Stephenson. Dr. Stephenson is a cataract, refractive, and complex anterior segment surgeon out of Venice, Florida, and I just learned today that she is soon to become a grandmother. Dr. Stephenson, thank you again for joining me today.
Thank you so much for having me.
Let's jump right into the case. So this is a 72-year-old woman who presents for evaluation of cataract surgery. She has a history of some eye infection, but doesn't really remember what it is. Her goals are to maintain the best quality of vision, glasses free. On exam, her vision is 20/60, and she bats to 2100. You note a faint mid-peripheral anterior stromal scar on the cornea and 2+ NS. Her dilated fundus exam is otherwise unremarkable, but biometry shows 2 diopters of astigmatism. Now, Dr. Stephenson, could you walk us through your standard cataract preoperative planning and evaluation?
Sure. And the thing is about when I think about a cataract patient, no matter who the patient is, I really want to start at the front of the eye and go to the back of the eye and everybody and not skip a part, because once you feel like you skip over on something, then you get burned for not covering it. So the first thing about this patient is, an eye infection of some sort and having a corneal scar. Now, this is a peripheral scar, anterior stromal. Did she have herpes zoster, simplex? Is the astigmatism irregular or regular? So those are things that, make me first want to look at the ocular surface and whether the lids and lashes and meibomian gland dysfunction and tear breakup time and the endothelium, what her endothelium looks like. Does she have iris atrophy from a zoster? Does she have findings that make you think that this was much more serious than just an eye infection? Because corneal scars can be very nominal or they can be very important, because if it was herpes zoster simplex, she would certainly be put on a PO antiviral long before she has cataract surgery. So in my practice, I'm a boutique practice. So about 87% of my patients are premium patients. However, I do the same thing for all patients. And, always look at the corneal surface, look at the health of the skin, and the lids and lashes are so important, and whether they have rosacea. But, I get biometry, a good slit lamp exam always, but, biometry with the IOLMaster 700 is my go-to biometry. I do a Cassini topographer, which Bluetooths to my LENSAR. However, the nice thing about Cassini is they have a video capability. So what this video does is it shows a pattern of tear breakup time. You actually see the patients blink. So you can tell where the dry spots are on their cornea. So you're already attuned to if they have dry eye, and then you can actually see it and show it to the patient. I actually also do an eye trace because it gives me a lot of information, whether it's corneal, and you can show the patient themselves. You look at the cornea as an entity on its own. You look at the lens as an entity on its own, and then you can add those together. And you're looking at a big E, so you can see if the cornea is fine and that scar's not in the way of her visual axis, then not to worry about it. If it's the lens and if they've had LASIK, not this patient, but if they've had LASIK, you can say your LASIK hasn't worn out. You have a dysfunctional lens and your cataract is causing the problem. And then you can look at what their image is at the end. I also do, I'm really big on looking at meibomian gland dysfunction. I look at mammography and, tear check, and I do the testing on the tear breakup time as well. And it's not subjective. You're not counting 1, 2. It actually measures the tear breakup time. So it's really a nice function. And then you can treat them preoperatively and then bring them back and actually show them like a report card that it's improved. So I think those are all really important things. OCT on all patients, I think, is really important. The difference is you can charge a patient if they have diagnosis. And for me, if I think about where I started 33 years ago and my naked eye looking at a macula, I cannot see what an OCT brings out. And, very subtle epiretinal membranes, And it's common in 10% of patients over the age of 55 or 50. And you want to make sure that, if you find it and you tell them and something doesn't go well, it's not your fault. But if you didn't tell them and you didn't tell them that they had dry eye or meibomian gland dysfunction, then it's your fault if their outcomes are not good. So that's kind of the basis of where I start with everybody. And, how I counsel these patients is the same based on what their needs are. And, realistically, if that scar is going to be a problem, then I don't think they're a candidate for a premium lens, a multifocal lens. They may be a candidate for a toric lens or a monofocal lens, and then later PRK for that area, or do we take care of it first, by doing scraping and then, putting a bandage contact lens or a one that's medicated, ProClear or whatever it's called. I can't remember what the name of it is. I'm not sure. I don't use them that often. But, you want to talk to them about, spectacle independence. And they did say they want the best quality of vision and they like to be glasses free. And I always tell patients nothing is 100%. And if they have monofocal with readers, will they be happy with that? And most people are. If they can see far away and intermediate, a lot of these new monofocal lenses, how they sit in the eye, the Bausch & Lomb's MX6TEs, ET, and Rayner's lens, and the current 611P that Zeiss puts out, and they're getting ready to release their 621 that has two zones, and it's aspheric in the center and positive on the borderline, but it actually negates the peripheral part of the cornea. So they really get an extended depth of focus with a monofocal lens. So a lot of times that answers itself. I'm not a big monovision per se. In my day, true monovision was like minus 250 in their non-dominant eye in plano, and their other patients cannot tolerate that. And the older they get, the harder that is for them. I do mini mono. A lot of these, especially if she gets a toric, you can do their non-dominant eye first, set them for like minus 50, and then go for plano or first click minus in their dominant eye. And they're really happy because they have a pretty good, and especially in good lighting, a pretty good excellent distance, pretty good intermediate, and a lot of them have near vision. So you want to under-promise and over-deliver. Really, important about the corneal health and the retinal health if you're using trifocal lenses, Lens Tech bifocal lens, or the Clarion PanOptics lens, or Technis, some of the Symphonies and the the iHance. Those are more EDOF lenses. And Vivity, you want to make sure the health of their cornea is good again, and because it can really take away their clarity and the quality of. They may be 20/20, but they're 20/20 unhappy because the quality of their vision isn't good. And so I think that's real important when you're advising patients on lenses. Always, the light adjustable lens is new in my practice, but I've been using it, and it's been wonderful. Especially, I'm getting younger and younger patients in their 50s, 60s that want cataract surgery. They've got big pupils. They're not going to be happy with the aberrations that some of the multifocals cause, and so I think that they'd be much happier with a light adjustable lens.
Absolutely. I think people are really excited about the light adjustable lens. And I think it's really important that you stressed how critical it is for us to assess the ocular surface,
Yes,
because
it's just so
people
important.
overlook it all the time, especially non-anterior segment people. You already touched on this a little bit, but for boards and OCAP purposes, what lenses cause kind of a higher risk of dysphotopsias? Obviously, we have negative dysphotopsias, which are the dark arcs that patients experience, and usually more common with a smaller square edge design, versus kind of those positive dysphotopsias where they see kind of halos or flares or arcs. And those are more common with a truncated square design and then in higher index materials. Are there any surgical pearls or lens designs that you think of to kind of minimize those risks?
Right. Well, first of all, too, backing up to the original exams, look at the higher order aberrations on the cornea already. So make sure higher order aberrations that you already know that they have it or don't have it, because you're only going to add to that problem. So safely, you can always put an aspheric lens in. And where you position the haptics, I think, helps. If you do it in the horizontal meridian, I think it helps with the dysphotopsias. If you want to optic capture, even if you think that the lens is just not sitting right in the bag and you don't want them to get that reflection from the bag not lining up with the optic, you can optic capture them. and anterior optic capture, posterior optic capture, whichever. And if you've violated the capsule, of course, the opposite, capture the optic posteriorly. But I think that matching the corneal abnormalities to the implant is really important. So I think that these new monofocal lenses that are aspheric, I don't think you're going to chase. I think we've made a mistake, in my opinion, chasing whether it's minus or plus. I think we always should be aspheric for several other reasons. As we're learning, and a lot of pathology doesn't come to our, it's not apparent when we first do it, but when we get in the operating room, such as these great microscopes now, you're looking at the cornea and you see a reflection of gutata, and you weren't expecting that, or that you notice when the lens goes in that it doesn't center correctly. So do they have a zonulopathy? So these aspheric lenses are much more forgiving. If there's tilt or if there is decentration, the risk of it affecting their vision, first of all, and having symptoms of negative or positive dysphotopsias are less. So they're more forgiving lenses. So I think that's always, it should be a go-to lens. Some of these lenses are fabulous if they're perfectly centered in the visual axis. And I would like to say every one of my lenses, I line it up to the Purkinje images of the microscope, but it doesn't end up that way. And I'd be being very untruthful if I said all eyes are created equal, because they're not. And we learn it the hard way. We learn it when the patient complains. So those would be my pearls, just to look at the higher aberrations first. And then, and of course, if they're post-refractive, it's a whole nother story.
Absolutely. And you use an aberrometer on all of your patients?
I have used Aura since I was the first person in the United States to have the commercial use of it. Actually, I did it the week before Bill Wiley, and Bill Wiley's my hero. He's actually sat on the phone with me. I'm sure you're his hero, and walked me through some unusual Aura. Back then it was orange, but I've used it, and we've come so far with all of our formulas, the Barrett, all of these great formulas, and the ASCRS website has all of them, and you can look at all of them. But our A scans have them all in them pretty much, so we can usually pick whatever we want. But Aura is funny; it's different. It has the WTF factor, that's the WaveTech factor, and it's factored in. It doesn't matter what formula you use to come up with your IOL; it has its own formula, so it measures everything and the posterior cornea as well. And it allows you to check it a second and third time when the patient's already had their cataract removed. And if you pay attention to your incision, the cornea, keeping it moist, ridding it of viscoelastic, so when you're taking the reading, make sure the intraocular pressure is good. I really think it helps you. And for me, it only changes what I do. Maybe it improves me 1%, but I'd rather be 1% better than 1% worse. So for me, I've learned how to use it and to manipulate it, and when to trust it 100%, when not to trust it 100%. So it really it doesn't add a whole lot of time, but it adds a lot of good for me. And I highly recommend the Aura, but it's got to be something you want to do.
Absolutely. And shifting gears a little bit here, what about the astigmatism? How do you like to deal with astigmatism? We touched a little bit on toric lenses. What about patients that don't want to pay for a toric lens? Do you offer them LRIs?
Well, I don't do any freehand LRIs any longer. I only do femto AIs. So I have a lesser package with a monofocal lens to take care of astigmatism against the rule or with the rule, depending whether you can do it with your incision and one AI, or if you do a paired AI. And I do it about 1.5 on the cornea with the lens. My choice is the LENSAR, and it has IntelliAxis, so it marks the CEEP axis, and it marks that your AIs are right in line. And if you're using a toric lens, anything over 1.25. But they have such low toric lenses now too, because B&L is plus 125 toric lens on the cornea, 0.9. And and I don't have a problem flipping my axis from with the rule to, or against the rule to with the rule. So I will treat 3/4 of a diopter of astigmatism with a toric lens and because my incision's at 12. I don't do temporal. I've just stayed at 12 because I'm manipulating back and forth on the microscope, my positioning, just because of my handicap. I don't change. So I've learned to be really good with the low astigmatism with AIs, but I also can do it really well with a toric lens as well, if they're willing to pay. If not, I do AIs.
Interesting. And just for our listeners, so the LRIs really have about a 65% depth, or the equivalent of 600 microns, versus arcuate incisions, which go 95% depth, but have a coupling ratio of 1, which means essentially that the spherical equivalent is unchanged. And then for the toric lenses, like Dr. Stephenson was talking about, you really want to remember that each degree of rotation reduces the effect of astigmatism by 3%. And it may induce higher order aberrations, and that's critical to remember. So if your toric lens rotates 30 degrees, you can expect there to be no change in astigmatism. But if it rotates 90 degrees, that astigmatism is going to double, and that's really important to remember.
Absolutely. And the nice thing with IntelliAxis, that LensR makes little marks on the anterior capsule. You can see because lenses are going to rotate in the first 24 hours more than any other time. And, you can see if the lens is aligned to the IntelliAxis the first morning. So it's really nice. And you could actually reposition it at the slit lamp if you need to.
Oh, wow. That's incredible.
Yeah.
How do you reposition it at the slit lamp?
Just go through your side port incision and just rotate it. If it's just a small amount.
Right.
But a lot of times it's right on, or most all the time it's right on. All lenses move a little bit.
Sure.
3 degrees maybe, but all of them move a little bit. But, the first day is really good. And I also, intraoperatively, after I place a toric lens, I remove all the viscoelastic, and I don't overfill the eye with BSS. And then I also I measure it with a tonometer, a barocara tonometer, and then I have them lay flat for 10 minutes in the recovery area. So I don't know, it's just anecdotal to me. And also in any high astigmatism, it's anecdotal, it's off-label. I put a CTR in patients because I feel like it locks the lens in place. I don't have a study on it, but any study, any data that I'm collecting on my patients, that any toric lens, they all have any toric, they all have CTRs. So I guess I could say, and my rotation rate's very small. And, so those are just anecdotal things that I do that work in my hands. And I'm not, advocating it. It's just something that I've learned after enough experience to my own gestalt, if you will, of how I feel that the lens is going to stay in the best position. And also too, with LensR, they have the way they make an AI, I use a 4.3 radius and it's 90% depth, but because of the angle that it's made, it's straight up and down. It's not angled. It's straight up and down, and it's made at 90%, and I open it, all of them, to 90%. If I make an AI, they're all opened to 90% depth. So, it's the only, it has to be all or none, because if you open some and you don't open others, you don't know what works. And if you're doing an AI, you've got to open it.
Absolutely. This just made me remember that I had a case recently of an arcuate incision that started leaking when I was on call, and we put a suture in it to help seal it. Have you had that happen in practice?
Of course. And I have put a suture in, and I've also put a bandaged lens, and I've also used sealants, and they took the sealant off the market. So
it's not cyanoacrylate glue. It's
it is a glue, but that's what it is. And you can use the glue. You could use the glue in the operating room and put a bandaged lens on, but it's easier just to put a suture in. And the bottom line is, it's easy to put in the suture, and it's easy to do it at the time of surgery, but it's really difficult to tell a patient, you know what, I should have put the suture in, and take them back to the operating room. So to me, better safe than sorry if you feel like it's going to leak. And I test all of mine to make sure they're not leaking. And it's just habit to test them all.
With just a fluorescein strip?
Fluorescein strip, and I press on the
little provocation with a fluorescein strip.
See if it makes any difference. Yes, absolutely.
It's a really great pearl too, to keep the eye a little softer, have the patient lay for 10 minutes. I think that's a really low cost, low impact way for us to help prevent rotation of the toric IOL.
Absolutely.
Dr. Stephenson, thank you so much. Before we end the episode, I ask all of my guests, if you could have dinner with one person from any time or place in the history of humanity, who would it be?
Leonardo da Vinci. And, to me, it's obvious. He put science and art together. And it's really what we are. We are really artists of caring for the eye. So to me, he's the guy I would want to talk to, just to pick his brain.
That's really beautiful. We are artists of the eye. I love that. That's a motto I'm going to bring into my everyday life.
Thank you.
Dr. Stephenson, thank you again for joining us on this episode of the Pupil Pod. And thank you to our listeners. Hope to see you next time.